Hi everybody, my name is Mitchell Farmer and this is part 2 of Lab 5 concerning the posterior abdominal wall and the retroperitoneal structures. So the first thing I wanted to discuss were the muscles of the posterior abdominal wall. We're looking at an anterior view here. We got our kidneys, and the first thing I'd like to discuss is of the muscles is the psoas major. Now the psoas major arises from the L1 to L5 transverse processes and the vertebral bodies of T12 to L5, seen here. It enters the thigh deep to, so if we just zoom in a bit here and move inferiorly, it enters the thigh deep to or posterior to the inguinal ligament. So recall the inguinal ligament extends between the acis, which I'm outlining here, and the pubic tubercle. We can see how the psoas major, highlighted now, travels deep to or posterior to that ligament in order to enter the thigh. Once entering the thigh, it attaches to the lesser trochanter of the femur. So if I rotate my model laterally and then posteriorly, we can see how it wraps around and attaches to this, which is the lesser trochanter of the femur, and this is the greater trochanter. The exact specifics of the osteology of the femur, as well as the more specifics on the action of the psoas muscle, will be discussed more in MSK block. So don't worry too much about that right now. Just know that the psoas muscle originates from the posterior abdominal wall, and also that is a hip flexor, or a flexor of the thigh. Lateral to the psoas muscle is the Quadratus Lumborum, which arises from the superior aspect of the iliac crest. If you recall the osteology of the os coxae, or the hip bones, this is the iliac crest, and this is the ilium. This is the iliac crest. You can see the Quadratus Lumborum arises from that crest and attaches to the lumbar transverse processes of the lumbar vertebrae, and it also attaches, what we can't see here, but it also attaches to the 12th rib, which is why it kind of looks like it's just cut off right here, attached to the lower aspect, or the inferior aspect of the 12th rib. One of the muscles I don't have shown here, but is listed in the dissector, is the Transversus Abdominus. Now, we've already been over the Transversus Abdominus, which is why I don't have it here, but recall that it arises as an aponeurosis from the transverse processes of the lumbar vertebrae, and it inserts into the linea alba and the inguinal ligament, highlighted here. The next muscle you might notice is the iliacus. The iliacus arises from the iliac fossa, which, if you remember, is this kind of indentation in the ilium. It arises from the iliac fossa and joins the psoas to form the iliopsoas tendon. So if I just put in the psoas on the left hand side, you can see how closely related the psoas muscle and the iliacus are, and they join together in the cadaveric dissection. You'll see that they join together and they both insert, if I rotate posteriorly, into the lesser trochanter via the iliopsoas tendon. The iliacus is also a hip flexor, much like the psoas major. And then finally, just moving superiorly, I'm going to zoom out a little bit. Finally, the last muscle of the posterior abdominal wall is the diaphragm, which I'll discuss a bit later in this lab. Although one note about the diaphragm in relation to the kidneys that I wanted to discuss is that the superior posterior aspect of the kidney lie in close relation to the inferior surface of the diaphragm. And just keep in mind that the left kidney is a little bit higher or a little bit more superior than the right kidney, as you can see here. And thus the left kidney is in greater contact with the inferior surface of the diaphragm than the right kidney. And this is presumably because the liver occupies such a large amount of space in the right side of the body, and thus the right kidney is lower. So I'm just going to pull up another view here, a view of the diaphragm. And just note that the relation of the kidney to the diaphragm isn't really well shown in this model. The relation is much more intimate in the cadaveric dissection. But just to discuss the diaphragm, basically its origins are the sternum anteriorly, the costal or lower 6 ribs laterally, which aren't seen, but posteriorly the lumbar vertebrae are the origins of the right and left crus or cura of the diaphragms, which I'm outlining here. and here. A note about the right crus is that, I'm just going to add the esophagus here real quick. There we go. Is that a portion of the right crust creates a loop around the inferiormost aspect of the esophagus. So I've highlighted the esophagus, and I'm zooming in. So recall that the esophagus enters the abdomen approximately the T10 level, and that the right crust would come up and loop around the esophagus, and thus would help form a sphincteric mechanism for when the esophagus transmits from the thorax to the abdomen. And that a weakening or expansion of this loop formed by the right crust of the diaphragm could result in what's known as a hiatus hernia, which is a sliding hernia, so to speak, where a portion of the stomach, which is the next piece from the esophagus, herniates into the thorax. And once it's herniated into the thorax, you can get reflux, which can often present as GERD in a patient. The last thing I want to talk about in respect to the diaphragm is some of its innervation. As you can see, there's two nerves seen here and here, the right and left phrenic nerve in regards to the diaphragm. The right phrenic nerve moves from the thorax and enters the inferior aspect of the diaphragm through the hole created, or the hiatus created, by the inferior vena cava, whereas the left phrenic nerve actually pierces the muscular diaphragm, or the muscular left hemidiaphragm. As you can see, it pierces straight through and comes out to innervate the inferior aspect of the diaphragm. Now these nerves are what allow us to breathe, allow the diaphragm to contract and thus lower. And so if you have a paralysis of, say, the left phrenic nerve, you would have a hemidiaphragm paralysis. The right side of the diaphragm could still contract and thus lower, whereas the left side couldn't descend. The last thing I want to note is that both these nerves arise from the C3, C4, and C5 spinal roots, and that can be remembered by the C3, C4, C5, keep the diaphragm alive, rhyme. So that's about everything I have to say about the diaphragm. I'm going to move on to the lumbar plexus as well as some more posterior abdominal wall muscles, or their relation to the lumbar plexus, which I will pull up here. So, here we have, just to reorientate you, the psoas minor, which may or may not be present in your cadaver, the psoas major, the quadratus lumborum, and then the iliacus, as previously discussed. I'm going to cover the lumbar plexus moving from superior to inferior, starting on the model's left-hand side, or your right-hand side, beginning with, and I'm going to zoom in here a bit, beginning with the iliohypogastric nerve and the ilioinguinal nerve. So starting superiorly, we have the iliohypogastric nerve. A couple things I'm going to add real quick here just to show you exactly how these transverse the lateral wall of the abdomen are the internal obliques and the transversus abdominis muscles. So the internal, or I'm going to start with transversus abdominis on the left side. So the reason that I've added this is that it shows how the iliohypogastric and ilioinguinal nerves pierce the transversus abdominis, but then they lie between the transversus abdominis and the internal oblique, so you can no longer see them. And if I fade the internal oblique, you can see how these nerves lie between those muscular sheaths in that space that exists between those two abdominal muscles. So I'm going to hide those now, just now that I've demonstrated that. So as you can see, these two nerves arise superior to the rest of the nerves of the lumbar plexus and arise lateral to the psoas major. So when you're trying to search for them, find the origin of the psoas major and then find the lateral aspect, and hopefully you'll be able to find them. So the iliohypogastric nerve pierces the transversus abdominis and travels in the space between the abdominal muscles, as stated. It then supplies perforating branches to all three of the abdominal muscles, or the trilaminar muscles, on their way to becoming positioned in, or as it makes its way to becoming positioned in the subcutaneous space. Now, what isn't shown here is that there's two branches of the iliohypogastric nerve, a lateral branch and an anterior branch. All that's shown in my model is the lateral branch, but there's also an anterior branch that supplies the suprapubic region approximately here. Whereas the lateral branch, as you can see supplies the more lateral aspect of the thigh. Now, the ilioinguinal nerve, after a period of travel, it pierces the internal oblique, as I showed you previously, and then travels along the inguinal canal. So recall that the inguinal canal is superior to the inguinal ligament, or posterior to it, more so, as the inguinal ligaments formed by the interning of the external oblique aponeuroses. So it travels along the inguinal canal to eventually emerge from the superficial ring, which recall is created by the external oblique aponeuroses, and into the subcutaneous space. Just as a note, it is not part of the spermatic cord and does not enter the canal via the deep inguinal ring. What its action is it provides cutaneous sensation to the superior medial thigh, as well as the anterior scrotum or / labia majora in females, and the penile root in the male. And that can kind of be seen through this extension of the anterior scrotal branch of the ilioinguinal nerve. So those are two nerves, and just to note that both of these nerves arise from L1, the spinal root L1. The next nerve that I'm going to talk about, now moving to the model's right, model's right or your left, is the lateral femoral cutaneous nerve. The lateral femoral cutaneous nerve arises from L2 and L3 spinal nerves, and it emerges lateral to the psoas major and passes deep to the inguinal ligament, just medial to aces. So if I move and show us a lateral view and zoom in a bit, we can see this is the inguinal ligament, this is the lateral femoral cutaneous nerve, and recall that this is aces. So just medial to that and just inferior to the inguinal ligament, you could see the lateral femoral cutaneous nerve traveling. It supplies sensory innervation to the skin on the lateral and anterior lateral aspects of the thigh, which you can see where that's approximately where it would exist. Now, moving on to the genitive femoral nerve, seen here. This is the femoral branch, and this is the genital branch. The genital femoral nerve arises from L1 and L2, and it should be relatively easy to find, as it emerges through the anterior surface of the psoas muscle, which none of the rest of the lumbar plexus does. There is as stated, a femoral and genital branch, whereas the femoral branch supplies a patch of skin overlaying the femoral triangle, which you can see it enters deep to the inguinal ligament. And the femoral triangle itself and what exactly that is, I'll discuss later in MSK, but just know that the femoral branch aids in supplying a patch of skin above that. Whereas the genital branch, if you kind of remember, we discussed this a few labs ago in the inguinal canal lab, in lab 2, it enters the deep inguinal ring and passes through the inguinal canal, and you can see it here passing within the spermatic cord. It enters the deep inguinal ring, and then it supplies the cremaster muscle and the skin of the anterior lateral scrotum and labia majora in females. And it is just a note, it is the efferent limb of the cremasteric reflex. Finally, we can discuss the femoral nerve and the obturator nerve. The femoral nerve arises from L2, L3, and L4 and can be seen on the model, highlighted on the model's left. It emerges lateral to the psoas and lies between the angle between the psoas and the iliacus. So here's the psoas, here's the iliacus, and in your cadaver dissection between the angle of them, you should be able to find the femoral nerve. It's an important muscle, and it's probably one that you're going to be able to remember come around to MSK, an important nerve, my apologies, because it provides motor innervation to the anterior compartment of the thigh, which will be discussed more in MSK block, and also supplies sensory innervation to the skin of the anterior and medial thigh, with the exception of the regions supplied by the ilioinguinal femoral branch of the genitive femoral and the obturator nerves. Now the final muscle, I guess the most important thing with the femoral nerve is that it supplies motor innervation to the anterior compartment of the thigh, and that'll make more sense in musculoskeletal block. The final nerve I wanted to discuss is the obturator nerve, seen here. It lies medial to the psoas muscle, and it's the only one that lies medial to the psoas muscle, so that should be a good way of identifying it. and travels along the lateral wall of the true pelvis. So recall that the true pelvis is formed just inferior to the pelvic brim, which I'm outlining here. It travels medial along the true pelvis's lateral wall and exits the pelvis via the obturator canal. So if let's zoom out here just to reorientate you where we're at. If I move inferiorly and we look at the pubis and the ischium, they form this area here, this hole, which is covered mostly by the obturator membrane. Now, there's a section that isn't covered by the obturator membrane though, and this is known as the obturator canal, through which the obturator nerve transmits. Relatively easy to remember. Now, the obturator nerve is important in MSK as well because it supplies the medial compartment of the thigh. The medial compartment, motor and sensory. So all of the medial muscles are supplied by the obturator nerve, which you will remember for MSK. So that's essentially the end of this video. Just kind of I know it's hard to remember all the spinal nerve roots and how exactly the lumbar plexus is organized. So there's a couple things that I helped use to, I guess, memorize exactly where those nerve roots are and what exactly constitutes the lumbar plexus. There's one mnemonic called 2 from 1, 2 from 2, and 2 from 3. Now what this is referring to is that there's 2 nerves from one root, that being the iliohypogastric and ilioinguinal are both from L1. So 2 nerves from one root. There's 2 nerves from 2 roots, that being the lateral femoral cutaneous and the genital femoral nerve. So the genital femoral nerve is from L1 and L2, so 2 nerves from one root, or from 2 roots, and then the lateral femoral is from L2 and L3. So those are the 2 nerves, and both have 2 roots. And then finally, there's 2 nerves that have 3 roots. There's the femoral nerve, and there's the obturator nerve, both of which are from L2, L3, and L4 spinal roots. And if you need to remember that these nerves even exist, there is the mnemonic I twice, in brackets, get lasagna on Fridays, which would be a mnemonic for I, 2 I's that is, I twice, iliohypogastric, ilioinguinal, get, genital femoral, lasagna, lateral femoral cutaneous, on, obturator, Fridays, femoral. So hopefully that'll help you remember that. I know it's a bit silly, but I had trouble recalling exactly the nerve roots as well as what constitutes the lumbar plexus, and that helped me out. So that's the end of part 2 of lab 5. I will see you for lab 6 or for repro block. Ciao.